some lack of coordination and some lack of access to healthcare, they formed the community level. This level included the primary healthcare management and technical committees that were able to take decisions at the local level. The ward development committees and village development committees were also there to take some decisions. And then in 2001 there was a survey of 202, and they found that only 27% of this community level was functioning well. It was not really functioning properly because there was lack of coordination from up. So with all of this, the interaction or the link between the three sectors is that the primary sector or the primary level acts like the entry point of the patient in all of the state. So if you have any health problem, you are expected to first go to the primary level. Then if they can't handle your problem, you are referred to the secondary level. If it cannot be handled, then you can be referred to the third. Here I want to ask, in case somebody is rich, what do we think will happen here?
Go straight to the tertiary.
Go straight to the tertiary. Why should you come here when there is a long line? They want to come here, and you can't stop somebody from going there. So this is where the management was not functioning well. And then doctors were the government employed people here more, and there were few people here. So if, say, I have malaria, instead of going here or at least here, I go to the tertiary. And if I am booked to come maybe in 3 hours, and then there is an emergency at this tertiary level where a serious patient is supposed to be attended to, obviously I will be kept aside. I will not be attended to. If you are in labor or you are a pregnant woman, instead of coming here to have the basics, and if there is complication, you are referred. Some patients who had their money will go to the tertiary. So there was crowdedness in the tertiary level of conditions that were supposed to be treated. So the government faced the problem of regularizing patients. Where are they supposed to go? What do we think the government can do to solve that problem? Shalom. If a patient decides, I have malaria, instead of coming here, I decide and I come here, how can this problem be controlled? Let me give a clue. If I pay 2 shekels to come here, and I decide to go there, how can that be controlled?
For example, more regulations like that, it's not more regulations like a law that it's not, even if you pay more, that it's not possible to just go straight to the tertiary, and that you really need a referral. Everyone needs a referral.
But now they could not control it.
But you ask for a solution.
Okay, so the government could put a policy. Is that what you're saying? Okay, that you should not be attended to at the higher.
Yeah, you need to have a prescription or referral that you can go there.
Oh, good. And this is what they did not do. But that was a possibility, that if they did like that, they would control people from leaving home and just going to the tertiary hospital. Yes. But what they did is that they increased the price. That if I'm supposed to pay here 2 shekels, if I'm coming to the tertiary without a referral, you pay almost 100 times that. You pay 200 shekels. But still, some people will still prefer that. So I think, as you're saying, the best thing that they could do was to bring out a policy on that. But because there was a lot of conflict between decision making, who were the people having power, and those who were at the lower level, this could not work. So they allow, and this confusion in the health system kept on for a very long time. Okay. Then we have explained the functioning of the system, and that is all. Is it clear here how they function? So there are so many things that in the healthcare system in Nigeria that is supposed to be done at the level of the functioning, putting policies, controlling, management. And another issue here is that the states here, they don't want to do anything because the government up here, they have given them responsibility and they are holding the financial responsibility from them. So it's like you give somebody something to do, but still you are still withholding most of the important aspects of it. So there is a lot of laissez-faire in the healthcare system. Okay, so who provide health care in Nigeria? We have the public sector, which is this, and they provide it through their hospitals and their clinics owned by the federal, state, and the local government, and it serves around 70% of the population. Still, we have the private. I need to learn again this thing. We have the private sector that is for profit making. We have the NGOs, we have the religious group, we have the traditional care providers, which is still a very huge problem in Nigeria, and we have community-based organizations. All of these five, they either fit here or they fit here. Since people pay out of pocket, it depends on you where you want to go. But at the private sector, most of the time the fee for service is very expensive. So people will always fall back here. Then for the religious, they have some particular groups of people that they cater for, like handicaps, like poor and vulnerable, like HIV positive children. So they have specific groups of people that they really want to care for. But if any other person can, they will still attend to you, but you pay some fee more than though if you are not eligible in one of the group. Most of them, they do that, but generally speaking, they also provide help for the people. The traditional care provider, these still remain as very effective as before. Most of the time, the population, they combine the two or even the three. They go to the hospital, they go to the traditional healer, they go for prayers. So somebody will say, okay, I don't know which one will work, so let me try all the three. Most of the time, they start with the traditional practices. When a child is sick, they go to the traditional healer, they want to take herbs, or they self-medicate. And this is mostly in most of the African countries. When I came to Israel and I had some headache, I went to a pharmacy. I thought I could just buy paracetamol. This was frustrating. I did not see, because in many of the African countries, every store has a pharmacy where you can buy the essential drug. So this practice, these traditional practices, and the fact that people can self-medicate, limits people from going to consultation, and this will be one of the challenges of this healthcare system. Then another issue is combining the traditional practices with health in such a way that there was a recommendation in Nigeria that whether you start from which itinerary, once you're in the hospital, you should be taken care of, because people will sometimes refuse care for the fact that they started somewhere else, which brought a lot of conflicts in Nigeria. Okay, financing. How is this healthcare then financed? Where we have different levels, we have different people. The first is from taxation, and tax revenue, that tax-based system account for a very low percentage, that is 18%. Yeah, 18%. And also the government is able to have money from sales of oil and gas. Then the out-of-pocket payment account for 74%. It's very high, and that was in 2003, but still in 2012 it's still very high, 70%. And here we see that most of this is where disparity and lack of access to healthcare count, because most of the population, we saw that unemployment rate was very high, dependency rate was very high. The elder depend on the young, the very small depend on the working class. So if you have a grandparent with you and your parents with you and your children with you who are not working and they become sick, you see that out-of-pocket payment here it's really a great problem, and it brings about poverty, hardship after payment of bills and attending to. So people fall back to their traditional practices. Then donor spending is also another source of revenue, and in 2008 it accounted for 0.8%. Sometimes it depends from what year or what issues are in the country, that funding, like Britain, they always support them with money, and WHO in case of other issues. Then they also have the National Health Insurance, which this idea of the National Health Insurance started since 1962, but because of their politics and people and the country political philosophy was not that to take care of everybody's health, it was not officially launched until 2006, when it was officially launched. But it is surprising that after this official launching, only 4% of the population was covered. The objective of creating this was to provide universal health care. So why did people not register or get involved? What do we think? If people have been suffering, paying money from their pocket, now in 2006, there is the official launching of National Health Insurance for everyone. Why is only 4% of the population covered?
Do people know about it?
That's another point. Maybe people were not aware. They make the decisions and papers are kept there, and they project it to the international organization for funds. Meanwhile, it is not, people are not aware. Thank you.
No,
Yes.
you're saying corruption. When you say Nigeria, you say corruption. So.
Okay, corruption. How do you think corruption would prevent people from enrolling in the?
Like what you're saying, people could enroll.
Yes.
At a government worker, but the actual enrollment papers or whatever fee doesn't actually reach the system.
How will the system benefit if people register and they don't project the results?
No, not necessarily to benefit the system. I mean, I don't think anywhere in the world people do corruption acts to benefit the system.
Okay.
so obviously, I mean, it was self-serving.
Okay.
Yeah.
Okay, self-serving, yes,
Right.
and that is the point.
Right.
That is the point. The problem stems from the wordings of this insurance policy. It stated that only federal government employee will be registered in this. So general people, as David said, they were not even aware. Those who were workers, they stopped them. They limited them from going there. How many people were working at this level? Because this is the federal government. More than 90% of the state works at this secondary level. So if you're making health insurance policy and you're saying it will cover everybody, and then you put a clause that it is only for the federal government employees, so very few people will go in for it. So this benefited the people who make the law. So this is where the corruption came. And then for the private sector, these people spell out that on the sectors that have more than 10 employees will register for. Is this really, does it give any meaning? So if I have 9 employees, I will not register for the universal health care. I tried to look in literature why this decision was taken, that only when you have 10, because these people, they also work, they also pay money to the government and all of that. But sometimes I thought it was because of the employers. They wanted to benefit because the employer himself will register. Then the other employee, they do not want to take responsibilities because they will be the one to insure the workers. And the greatest problem was that even those who had more than 10 employees, they will not register all of them. They will not register all of them. So if I have 25 employee in my company, I will register 8. I won't pay taxes for those people. I won't insure them. And the money they are working is not going to the government. It goes into my pocket. And the people keep on suffering. So this is what I call here. I'm happy it went down. I call them under-table workers. And it really went on the table here. Thank you. I call this term under-table workers. They are working. They are not registered. Employers, in a city, they will decide to spread their business into 10 different places and employ few workers in all of that. And if you combine that single person's business alone, they will have more than 100 workers. And this is where this corruption came in. The government was not able to have revenue. They were not able to sustain the universal healthcare system. As we said, the number of people who register for health insurance matters. So only 4% of this population registered. So where will money come from to be able to then take care of this? So this system is in papers, but it is not functioning at all. Okay, then let's go to the last thing. Very soon I'll start. Healthcare expenditure. They don't have. So why should they even spend more? In 1998, they spent 5%. 1999, it dropped. 2000, it dropped. Continuously until now, until now they are 4.7 of the total healthcare expenditure. And in 2001, the Abuja Declaration, that is members of African Union, signed a budgetary allocation for healthcare of 15% as compared to WHO that recommended 13%. Many of the African countries, did I put them here? Yes. They respected this. Rwanda was at 18%, Botswana was at 17.8%, Malawi was at 17.1%, Zimbabwe was at 16.4%, Burkina Faso was at 15%, and then the mighty Nigeria remained at 7.4%. So what is then their philosophy of healthcare? And they are talking about universal healthcare. It can't work there, or it is not functional. Then, okay, I've said this, that here it is 4.7. And if we translate these figures, it will give us these big billions. Their GDP in 2017 was 7.2 trillion, and the healthcare expenditure was 304 million only. If we do the calculations, we'll see that per capita spending is 1,688. I'm not talking about 10,000, 1,000, as compared to 3.5 million per prisoner in this day in 2017 in USA. So Nigerian government is actually spending nothing on the population as far as healthcare is concerned. Then also WHO minimum for Nigeria, they said if they are able to prioritize their health, they are supposed to spend 6,900, okay, almost 7,000 naira. That is 1.2 trillion for their total population. But they are spending under this billion, and they are spending, instead of 6,000, they are at 1,000. So much still needs to be done at the level of the government philosophy. If truly they want to provide universal healthcare, then they need to make a lot of reforms and changes. Okay, this is my last slide, please. So I put this slide just to show the different changes that occur. Here we are having from 2013 to 2014, there is a minus in change of the total health care. And if you look over the trend from 2003, we have 1, 2, 3, 4, 5, 6 minuses, meaning that when you improve this year, the next year it is short. When you improve, the next year it goes on the negative side. So this is how they spend their money. So I am here concluding that, okay, yes, please, just one more. The Nigeria unrealistic budget, this is the second to the last. The amount is unrealistic to tackle the main healthcare problems, and the talk less of the universal coverage, because it cannot cover people. But even the small cannot cover the lesser fever outbreaks that are consistent in Nigeria, the high maternal and child deaths, the poor primary healthcare facilities that they are unable to maintain. You go to some of the places, you see those buildings and the pens that were done by the British, nothing has been done on it. Lack of functional cancer center machines. They have invested in cancer and they are unable to buy the machines, and the structures are standing there. There is still a lot of malnutrition. There is poor response to emergency. HIV/AIDS has also brought its own issues, and malaria remains a great problem. And yellow fever is also a problem, and some statistics show that in 1985, around 1,000 people died. More people were infected, and this amount died. So the various statistics show that Nigeria has one of the worst health records in the world. Based on the GNP per capita, Nigeria is still among the poorest countries in the world. Okay, so these are some few challenges that I try to sort out. There is still limited institutional capacity to be able to handle the health problem. Corruption is a big issue from one angle to another, from the top to the bottom, from the doctors to the nurses to the health community. When money is concerned, sometimes it's difficult to resist those corruptions. And unstable economy. Of late, the Naira, there's some sort of devaluation. It has reduced again, so obtaining international things is also very difficult. Political context remains the problem between the Christians, the Muslims, the Boko Haram. Money is being used for health to fight against Boko Haram. British has given money for improvement of health care structures, and it is being used for political reasons and all of that. Most difficult is the confusion in the role and the responsibility of all of these three levels, duplication of function and overlap. And all of this is leading the trained, the talented, the young nurses and doctors and the workforce going out of the country. Thank you for your kind attention. Yes.
Any quick questions?
Yeah, so Isabella, you never touched on the issue of power supply.
Power supply?
Power supply, yeah.
What is power supply? Electricity?
Yes.
Oh, and focus mostly on
it's
health.
a major issue in Nigeria.
Okay.
In fact, they have what they call rolling blackouts, like load shedding.
Yes.
Where it's customary, for the whole country to go through these timetables of cutting off electricity. So
For more than 1 week. And this is affecting the healthcare system seriously.
Yeah.
It is a global problem even in Africa, even in Cameroon. They have resources.
But
They have resources to be able to put this power, but how the government allocates, and all of this is about the corruption. Where is government allocating its resources? Is it where it is supposed to be? Or maybe you have any other ideas what happens in Nigeria as far as that?
Yeah.
when you don't have a society that functions by rules, you can't have systems that. Danielle?
Really quick. I'm a little bit, could you say anything about the Ebola crisis? Because they contained it pretty well, didn't they? Not surprising based on.
So you're too fast, please.
Oh,
Sorry,
sorry.
I've forgotten. Yes.
Did you find any information on how they contained the Ebola outbreak?
Okay, in Nigeria, yeah, there were some crises. There were some people. Some were sent abroad, and some were treated. The death, there is some information about the number of people who died, but there was an intervention from WHO. Yeah, and there is now a well-structured surveillance system. But how many people then go to the hospital? There are signs and symptoms, but when they have those signs, if you have any bleeding nose, they are rushing to the traditional healer. So they are trying also to sensitize almost the whole population that when you have this or that, come to the hospital. And particularly for the case of Ebola, there were some meetings with the traditional healers, because this is where people will most of the time go. In the hospital, the healthcare professionals, they are aware, so they can report. But with the traditional healers, they tell them that this is a very contagious disease. You see somebody like this, you call, they will refund your money, they will come and pick you up, and the person and they follow. So there has been much done in case of Ebola. Yeah, thank you.
Okay, we will take a break for lunch now. It's 1 o'clock. Do you think we can do 45 minutes? Okay. 1:45.
It's pretty short, so I wouldn't have to reserve too much time for it. If that's not enough time, my presentation's pretty short, so,
No, you'll come in after lunch. Okay?
Yeah.
All right, so should we have an hour, in other words? I mean, we've got other stuff we have to do. We're gonna hear about Saudi, and Ilya's gonna do a presentation as well. Is an hour better? Fine. Okay, so 2 o'clock, we will resume. Please, let's really be on time, okay?